So our first speaker for the night is Mrs. Maxine du Toit. So she is a genetic counselor in private practice. She's been HPCFA registered since 2020. That's also when she started her private practice. So she practices in the Belleville area, and she also sees patients once a month in Paarl and Somerset West. So she's going to start off, and her topic is going to be referral guidelines to when to refer to a genetic counsellor.
Good evening, and thank you, Chantal. So yes, I'm Maxine du Toit. I'm a genetic counsellor, and I've got the opportunity tonight to just give you a bit of information on the reason why we exist in the cancer context. So genetic counselling is specifically there to provide support for your patients, for those at an increased risk of a cancer predisposing syndrome. So often the patient who is cancer, clinical decisions need to be made, and sometimes also patients who's got a family member who's affected. So the goal of genetic counselling is to help people understand and adapt to the implications of testing, but on various levels, on a medical level, psychological, psychosocial, and familial. So it's not just a testing that is done in isolation, but thinking about the implications all around. A big part of genetic counselling is helping patients to make informed decisions. So establishing informed consent regarding genetic testing. Sometimes patients think that why can't we just mark something off on the form? But there's so many things that need to be taken into consideration to help them make informed decisions. That is also part of the genetic counselling process. Part of that is looking at what the benefits, risks, and limitations are of genetic testing, and also the different testing options and strategies. It's also important to prepare a patient for what the potential result could be, whether it's a positive, a negative, or even a variant of uncertain significance. So it helps a patient to be prepared to think about what the answer can be and help them think about how is this going to affect me going forward, whatever the result may be. It's part of making the process, I think, a little bit easier emotionally for them as well. You know, coming to terms of what the result could be and what the way forward and recommendations could be. And then also speaking about the potential options for managing risks based on the results. So, as you can then understand, we usually have a pre-test genetic counselling consultation. That is where we sit and we do the family history, talk and help the patient see everything in context, make informed decisions about testing, and then once the results are available, sit delivery consultation. So it is internationally recognized and recommended that all genetic testing be performed in the context of appropriate genetic counselling. This slide shows that has been published by Greenwood Genetics Centre, shows very nicely the benefits, considerations, and limitations of genetic testing. So this is a big part of also what goes into the genetic testing of the genetic counselling. So speaking to the patient about benefits such as that the result could potentially provide an explanation of the history of cancer, that it could help with making medical management decisions, especially when it comes to management, when it comes to decisions like a lumpectomy versus a mastectomy or double mastectomy or ovarectomy, that kind of thing. And it can also provide information for family members. But skipping to the other side, limitations is that also that a negative result is mostly informative when a familial mutation is known. So not necessarily when you've got a patient and they're, for example, unaffected, their mother passed away at a young age of breast cancer, but there's never been genetic testing done. If she tests negative, it's not as informative because we never knew what the original mutation was, or if a mutation could have been picked up in her mom in the first place. So there are those kind of limitations for a patient to understand going into the testing process. Testing may also not be able to detect all genetic changes. There could be variants that's so rare that current technology cannot pick it up. And it can also be that there's a mutation in genes that's not yet associated with breast cancer that we still need to learn a lot about. And then the variants of uncertain significance. that is very important to prepare a patient that is something that is a possibility, because that is something that can create a lot of uncertainty and anxiety for a lot of patients. So things to consider is the psychological impact for yourself, your sibling, your children. A normal result could give false reassurance, like in the example of a mother passing away at a young age, daughter testing negative, because we don't really know what we're measuring her negative result against. And then also things like helping patients to think about, before I get tested, especially in the context where a patient doesn't have cancer yet, is, do I have policies in place? Do I have a cover for dreaded diseases? So that kind of thing for patients to think about and make informed decisions. I mean, there are certain situations where patients decide to wait a little bit with testing or not to go ahead with testing, depending on the specific situation. This slide, also by Greenwood Genetic Centers, shows us that most of our breast cancers and most of our cancers in general, sporadic in nature. It's not because of our genes. However, up to 10% of breast cancer cases may be hereditary. And that is where we find a specific spelling error, we put it that way, in one of our cancer genes. Most people know about BRCA1 and BRCA2, but that bracket, that 5 to 10%, also takes into consideration other genes that there could be a mutation in. And then our 10 to 20% familial category is where there isn't specifically a spelling error that we can currently pick up, and it could be that there's multiple genes involved that increases the risk in a specific family for cancer. But it's not necessarily so easy to then give specific yeses and nos and numbers to patients. So all of this needs to be explained to a patient that they understand it nicely in context. So the question, just to skip one back, is when do we know to refer a patient? Not, as we can see with our sporadic category, not every single person with breast cancer needs to undergo genetic testing. But there are certain red flags, and this is where it's nice to have a little bit of an idea of when we refer patients. And I'm going to get to that now, but in this next section, I'm making use of this lovely article that was published in 2020 by the Pathcare Genetics team that looked at pickup rates, specifically in our different gene panels. And so I'm going to be also referring to the information that comes from that very nice summary that they've written. So testing criteria guidelines, there's a lot of international groups that have published guidelines, but there's nothing that is specifically published for our local cohort. But however, specific units, academic units like Tigerberg or UCT have published, they've got their own guidelines of who should qualify for genetic testing. And then also us genetic counselors in private practice also have got an idea that we've also got a bit of a twist or how we feel, each one of us, of how we should, patients be referred. This is so that it can take into consideration the fact that there's founder effects among certain population groups, like we know about our founder mutations in the Afrikaner and in the Ashkenazi Jewish population, specifically in BRCA1 and 2. And then also some things to take into consideration is medical aid option versus what international testing is mostly out of pocket. Strict testing criteria can lead to missing genetic variants. And then that is why, very interesting, the next part is that the American Society of Breast Surgeons recommend that testing all patients with a personal history of breast cancer. But if it's a patient that was diagnosed over the age of 65 years, doesn't have a significant family history, there's a very low probability of finding a result with clinical utility. So it's a little bit of a balance of who to refer and who not to. This is an example of the NCCN guidelines that's quite complex if you look at just for the top of your head. But for example, these are guidelines in private practice that I like to use that has been adapted a little bit from the NCCN guidelines when to refer. For example, if it's a breast cancer diagnosed under the age of 45 or by the age of 45, or if it's in the category of 45 to 50 years with one or more of the following, such as an additional breast cancer primary, or a close blood relative with breast cancer, or a relative with pancreatic cancer. So these are all our red flags that come up, multiple cancers in one family member, or multiple cancers that we can group together that we can associate with specific genes. And then also an unknown or limited family history, because if we, for example, work with a family where there's mostly male family members, and if it's a BRCA mutation, the risk of presenting with a breast cancer and even a prostate cancer is less than if it was a family of mainly women. That kind of thing needs to be considered as well. Then also our triple negative breast cancers diagnosed under the age of 60, and breast cancer diagnosed at any age with any of the following, and a little bit of it is repetitive, but having guidelines like this to help you make decisions can be very useful. I'm assuming the slides will be available. But yeah, everybody's got a little bit of their own take on these guidelines, but this is a general guideline that one can look at. A personal history of ovarian cancer and a personal history of male breast cancer, those are definitely reasons to look into genetic testing. So this is specifically our PathCare study that looked at the patients that they saw in their center, and in the period of 3 years between 2016 and 2018, where they looked at the positive pickup rates within the founder screen, in-house BRCA1 and 2 full sequencing, and also the international multi-gene panel sent away to Invitae in the USA. So here we can see that in our Afrikaner, for patients who doctors or genetic counselors just request the Afrikaner founder testing, we see that there's a pickup rate of about 15%. And in the Jewish founder screen, a pickup rate of about 8%. So one would ideally want to test a little bit broader. And the thing about founder screening is that it can be a sensible place to start with testing, but it needs to be followed up with more comprehensive testing if we find a negative result. Because otherwise, patients can very easily have a false sense of reassurance that I do not have a mutation in this gene, but actually it's a mutation that lies somewhere else in the gene. And then when we look at our BRCA1 and 2 full sequencing done at PathCare, and they found a pickup rate of about 7%. So now we ask ourselves, is this good enough? Can we look a little bit broader? And that is where our genetic panel testing comes in. And I'm sure by now most people know about the different panels that's available through Invitae. And also part of the genetic counseling is helping patients understand why a certain panel could be a better option in a specific case. So this graph shows very nicely that the breast cancer stat panel has a very, it's a good pickup rate of 21% and a VUS rate of about 20%. The Invitae breast and gynae cancers guideline-based panel, where they analyzed 20 genes associated with breast and gynecological cancers, 17% pickup rate and about a 20% rate for finding VUS. And then we get to our Invitae common hereditary cancer panel, which is a much larger panel where 47 genes are analyzed, but where you can see that although the pickup rates, the positive pickup rates are relatively in the same range, suddenly we see a lot more VUSs come up. And this is something to prepare your patients for. And I like to tell to discuss with my patient that there are certain genes that we definitely have to look at to try and find an answer for your cancer or for the family's cancer. But then there's the option of looking a bit broader, but as long as they understand the context, as long as they understand the larger we test, the more VUSs we will find, the greater the chance of finding variants that's not typically associated with the condition. It's very important for patients to understand that, especially to help with managing anxiety and uncertainty. And then my last picture that I want to show you is also still from the same PathCare study, where PathCare found that their multi-gene panel results, it shows us the different genes in a pie diagram together, different sections, where you can see the amount of BRCA2s being found, BRCA1 mutations, CHEK2, ATM. So it just comes to show that if we only analyze BRCA1 and BRCA2, we will be missing about 40% of mutations that can play a big role in the family and in the patient's health. So I think that's also what we're going to be discussing further tonight is, looking beyond also BRCA1 and 2. It's a great place to start, and it's also important to look at the family history, because if you've got a family history that is very strong, only a BRCA1 or 2, that might be good enough, and especially if you find an answer. But when it comes to family histories that not so clear cut, it's really important to look broader, and it's really important for patients to understand the differences and what is available and the various options. But just to mention that this pie diagram is specific to the PathCare cohort that was analyzed, and each center will have a bit of a different distribution. That is, I would like to hand over now. Thank you.